Hey guys, welcome back to the Holistic Rehab Room. Today we're going to be going over neck of femur fracture. Neck of femur fracture, the definition. A fractured neck of femur is actually a serious injury, especially in older people. It can be life-changing and threatening, and it occurs when the neck of the femur is fractured, so the bone fractures. Etiology. So there are low energy injuries and high energy injuries. So the low energy injuries will be those such as falls in frail older patients, those that have osteoporosis and osteopenia that puts them at a higher risk of getting a femur fracture. Then you have the high energy injuries such as RTAs, road traffic accidents, collisions affecting the ipsilateral side. A little bit more about the neck of femur. So the neck of femur is around 30 degrees to the shaft, also anteverted by roughly 10 degrees, with the femoral head in the acetabulum. The femoral head's blood supply is primarily unidirectional, mostly arriving from the medial femoral circumflex artery, arising from the deep femoral artery. The medial femoral circumflex artery lies directly on the femoral head, thus it's vulnerable to damage in fractures. The epidemiology, so the average age is usually 77 years old, and women are usually more susceptible than men. The NICE guidelines, according to the NICE guidelines from 2017, women are at higher risk of osteoporosis, so it goes from 2% at 50 years of age to 25% as you age over 80 years old. And also they're at increased risk of osteoporosis once they go through menopause, but both men and women are at risk of loss of bone density due to age-related changes. Classifications. So we have the intracapsular, the extracapsular, and then we're going to go over the guarding classification. So intracapsular is the subcapital through the junction of the head and the neck of the femur. So you have the basocervical fracture, which is through the base of the femoral neck. And then you have extracapsular, so the intertrochanteric, which is between the two trochanters, the greater trochanter and the lesser trochanter, and then you have the subtrochanteric, which is less than 5 centimeters distal to the lesser trochanter. The guarding classification, so you have the guarding classification, and then we'll talk about the simplified classification, and then we'll go over the description. So guarding classification 1, that is a non-displaced, and that means that it is incomplete. Guarding classification number 2, we have non-displaced. It's a complete fracture, but it's non-displaced. Number 3, or grade 3, classification 3, is displaced, complete fracture with partial displacement. And then 4, we have displaced, complete fracture, fully displaced. Clinical features. So, has the patient had a history of recent falls or trauma? Do they have significant pain, which is usually in the groin, over the hip, in the thigh, or the knee? They have an inability to weight bear. You may see a leg length discrepancy, so you may see a shortened and externally rotated leg due to the pull of the short external rotators. You may see the patient have pain on pin rolling and axial loading, and they will be unable to complete a straight leg raise. Complications. So you got joint dislocation, aseptic loosening, which is failure of the bond between an implant and a bone, no infection. Then you have periprosthetic fractures, and mortality following a femoral neck fracture is up to 30% at 1 year, and 10% die within 1 month, and that's according to the NICE guidelines from 2017. Medical management. So Patients may get an ORIF or a dynamic hip screw, and an ORIF is an open reduction internal fixation. This is a type of surgery that is used to fix the fractured bone. It's a two-part surgery, so step 1, the broken bone is reduced or put back in place, and then step 2, the internal fixation device is placed on the bone to fixate it in place. Then you have the dynamic hip screw. That is the metal plate that is being placed along the outer side of the femur, and a screw is put through the neck of the femur to the head of the femur. And this is typically used when the fracture is extracapsular. The advantages of the surgeries are the patient is able to stand, they're able to walk, they're able to weight bear, and it gives the hip joint stability and increases movement, thus reducing pain and discomfort. It also allows early mobilization of the patient. That also will depend on the surgeon's call if they want full weight bearing, partial weight bearing. It all depends on that as well. Okay, so what you want to do is you want to do a multifactorial assessment. You want to look at the fall history. Has the patient fallen in the last 12 months? Where was the fall? Were they able to get up? Did they require help to get up? Also, you want to check their gait, balance, mobility, their muscle weakness. You want to check their osteoporosis risk. You want to check their functional ability, and if they have a fear of falling, can we move past that fear of falling? Can we work on that fear of falling? Also, we have the assessment of their visual impairment. Is their vision intact or is it impaired? Do they have full sight? Do they have partial sight? Are they blind? Are they legally classified as blind? And then you also want to look at the home hazards. Are there any falls risk around the home? Do they have lots of rugs, mats? There's a falls risk. And you also want to look at what type of shoes they are wearing or what footwear they are wearing. Are they wearing flip-flops, which put them at an increased risk of falling? Do they have closed-toe shoes? Are they wearing shoes indoors? Are they barefoot? Do they have socks on? Are these non-skid socks? You want to take all of that into account when doing the assessment. And falls prevention. You want to do falls prevention. People 65 and over are at an increased risk of falls, and you also want to see, as I said earlier, you want to ask about have they had any falls within the last year, the frequency, the context, and the characteristics of that fall. And we can also add in an assessment to assess the patient's balance, such as a Tonetti, a Berg. You can use a dynamic gait index, and that will provide you some information on that patient's balance and how high a risk they are of falling. Okay, but thank you guys so much for tuning in to this presentation, and I hope you've learned something. Please like, share, and subscribe. Thank you.